Morning. How's everyone? Thanks for being here. I want to thank Cindy and the folks here at Meadowbrook Library for hosting us in their beautiful facility. My first visit, I'll admit, confess. But we're glad you all are here. We are conducting a series of these discussions across the New River Valley. This is our fourth in the past week. So we've been to Pulaski, Giles, and yesterday we were in Floyd. And so very similar format, very informal. You are getting a free lunch, but the catch is you have to talk to earn your lunch. So we want to hear from you. Holly and I are going to help facilitate, but we're not here to lay info on you necessarily. We want to get input from you all. We'll talk a little bit about the Recovery Ecosystem project, briefly about that, but it's really about getting your thoughts, your ideas, your suggestions, your concerns about this issue that we recognize and understand has affected so many of us, directly or indirectly. With that, I think we'll do a quick round of introductions, and we'll start with you. Just tell us who you are, where you work, and keep it short and sweet.
I'm Ryan Stanley, and I am interning with Holly at the New River Valley Regional Commission.
Tell you what, take the mic and just hold that as you introduce yourself, if you
Okay.
wouldn't mind.
I am Sarah Frazier with Carillion Clinic.
I'm a resident physician at Lewiston Recovery, working with Dr. Faisal.
Chelsea Beatty, Virginia Tech, the Center for Service Learning.
Hi, I'm Patty McComas Hall. I'm with the Women's Resource Center in the River Valley.
Hi, I'm Sophie Ward. I'm also from the Women's Resource Center of the New River Valley. And I'm Matt Fidel, and I'm also from the Women's Resource Center. Thank you.
I'm Pam Ray with New River Health District.
I'm Morgan Hilton with Community Housing Partners.
I'm Jamie McReynolds with the Blacksburg Police Department Citizens Advisory Board.
I can't hear anyone. Can you all hear me?
Yes.
Okay. Must be the fan. My name is Victoria Taylor. I'm a licensed acupuncturist, and I have had a contract with New River Valley Community Services for the last 20 years, teaching and providing a form of acupuncture that is designed to be used in recovery programs.
My name is Kat Saunders, and I'm retired but semi. I work for Bradford Counseling, DOC, VASAP, and I'm a acupuncturist, ear acupuncturist, auricular acupuncturist, detox specialist.
I'm Eleni Bishop, and I work with Montgomery County Department of Social Services.
And I'm Leah Hill. I work with New River Community Action Head Start.
I'm Andy Gillespie with NRV Cares and the NRV Resiliency Network.
I'm Katrina Nelson, and I'm also with Montgomery County Social Services.
I'm Tara Hanks, and I work here at Meadowbrook Library as the assistant manager.
I know. I don't need a mic. I'm Cindy Manning with the Meadowbrook Public Library, and I'm the branch manager.
Chris Alderman with New River Health District.
Grab a mic, Sophie.
Yeah. So sorry, I'm late. Hi, Sophie Wenzel, Virginia Tech Center for Public Health Practice and Research, New River Health District.
Did we get everybody? Okay. All right.
D.
Oh.
D.
I'm Dean Frith, NRVCS, and food.
I'm Holly Lesko, New River Valley Regional Commission Director of Community Health.
And I'm Mike Wade. I work for New River Valley Community Services. Who do we miss?
Ross.
Ross. Oh, yeah, Ross. The man behind the camera, Ross Wilsey with my team at NRVCS. All right. So we are going to, again, talk briefly about the Recovery Ecosystem project that's been funded by the Opioid Abatement Authority settlement. But then we're going to jump into talking specifically about 4 different categories pertaining to overdose addiction in general. And those include prevention and education, harm reduction, treatment, and recovery. Okay, so once we talk a little bit about the opioid abatement settlement project, we'll break, grab lunch, get back to our seats, settle in, and then we'll take about 15 minutes for each of those 4 topics that I talked about to move the discussion along. Okay? Sound good? All right, Holly, it's all yours.
Hi, everyone. You've got a kind of overview sheet in front of you about the New River Valley Recovery Ecosystem program that is funded through the Opioid Abatement Authority for the state. Does everybody have one? Oh, yeah. Okay, so essentially what this is those of you who are my age or older might remember Tobacco Commission funding that came through when there were settlements made with tobacco industry about the dumping of that into our region. This is the opioid version of that. The state is still in the process of settling with several drug makers and pharmaceutical companies, as well as pharmacies who were inappropriately dumping opioids in our region, across the nation, but particularly in Appalachia. We got some pretty heavy doses. This money is, the state has decided that the way that Virginia is going to allocate this funding is there are direct distributions to each of the political bodies in the state of Virginia, which include counties and cities. Towns within counties are part of that, but they do not get direct allocation. So counties and cities get direct allocation from settlements, from each one of the settlements. Those are continuing to move forward, so there probably will be different amounts of money coming in the future. And then the state also held back some of that funding directly to make competitive awards to localities as well as to state agencies in the state of Virginia. That is the piece that we're working on here. The New River Valley came together in true good New River Valley fashion and did an application regionally for a collaborative, cooperative application to the Opioid Abatement Authority. The localities did, as part of this application, commit to using their direct allocation of opioid abatement money towards this cooperative work. So there's about, and I was just talking to them on the phone today about this, are different buckets. Some is direct distribution, some is direct allocation from the Opioid Abatement Authority, and then some is competitive allocation from the Opioid Abatement Authority. So about 1.2 million comes from that direct allocation, either directly from the settlements or from the Opioid Abatement Authority, and then the rest was competitively awarded to. We're about $3.4 million to spend in this first year for this work, which is what that document kind of shares with you, the general buckets, if you will, of the way this funding is going to move forward. There is a leadership team made up of each representatives, high-level leadership representatives from each one of our local political governments. I keep struggling with that language, as well as the organizations, regional organizations, who will be primarily involved in the boots on the ground, the actual work of this effort. That group is meeting on August 30th to make sure that we're fully aligned with the proposal that went in May, as well as to, there's lots of political pieces that have to move forward, resolutions of support from boards of supervisors and city councils, as well as memorandums of understanding that have to be signed with Montgomery County, who agreed to be our fiscal agent for this project. So our hope is by, fingers crossed, I'm a hopeful person, middle of September, beginning of October, we'll be able to really start implementing a lot of this work. Some organizations, such as mine, the New River Valley Regional Commission, is functioning as I get to do some of this work as part of my work with them, regardless of the funding coming forward right now, because we are officially allowed to spend as of July 1, but not everyone has money that they can, allocate to that until the funding comes through. So some of these pieces we're waiting on, and some people are moving forward with a few of the pieces, such as anti-stigma campaign. There is a mobile unit that the health district got at the end of the, oh, there she is. A mobile unit that New River Health District received at the end of the pandemic as part of a local government pooling together. Weren't able to use it as ideally as we'd wanted during the pandemic because of all the rules and regulations that needed to come together to make that happen. But it is available now, and we're coordinating with different organizations and the health district to try to get that mobile unit out and circulating around the region so that it can provide both services, general health services to folks, vaccinations, STI testing, information, education, as well as some of our harm reduction and treatment opportunities that will be available through this funding source. There's also an expansion of treatment facility with the New River Valley Community Services. The New Life program currently has 10 beds, will be expanding to 17 beds. Hopefully that will happen within this fiscal year. There's a lot, that is plans on the books already. And then some study around things like supportive housing, adolescent treatment, and some other elements around education and prevention that we're taking a look at. And there will be a lot of activity happening, and what we know is nobody can do this alone. The intention of this proposal was really to try to break down silos and enhance communication across some of this work. We're all very busy, and it's sometimes easy to get our head down, and moving forward, this work is intended to create a more collaborative, more cooperative work in that space, as well as make it possible for people who are seeking treatment, resources, and prevention activity have a no wrong door access to that. If they have a relationship with somebody at NRVCS or somebody at the health district, even if that agency can't provide that service, there will be an easier way, hopefully, to communicate that to the organizations that can. So with that, if there are general questions about the proposal or the way the money's going, things like that, I'll answer it to the best of my ability. But also, this is still an opportunity for us to gather information about what you think Montgomery County most wants us to be clear about focusing on as we move this forward. Yeah, Jamie.
Is there any impact from the...
I'm sorry.
Is there any impact from the Sackler case being held up?
Not with this current funding. That piece
That
still
doesn't-
wasn't, as I said, there's a lot that are still in the resolution phase. It could impact out-year funding, but it won't impact any of this current year funding. Anything else? Yeah, Sarah.
For the bullet point of evaluation and performance measures, will any of that data be shared publicly? And I ask that because I can use that to help shape my job role at Carillion, because Carillion loves data. And it is part of my job duty to support networks in the NRV that are focused on substance use. So I can do that. And one possible opportunity, after speaking with my friend Ryan here, is serving as a mentor for MPH students, because Carillion gets asked quite a bit to be a location for educational opportunities. So that's one way to use it.
The intention would, it's hard to hear. I know some people are, I know we think it amplifies, and I wish it did, but those people got it. Essentially, Sarah was asking about evaluation and how that data might be shared as we're doing an evaluation. The intention of that work is for it to be iterative and that it will inform the work. So yes, to the degree that it is appropriate to share information that isn't too individualized or protected in some way, yes, data will be shared and data will be collected, because what we also need to be able to show, one of the things about this award and that the settlements that are happening with a lot of these drug makers is that if we are not making impact, it is an opportunity for them to claw money back. That is pretty clear in this. And some of that is because of what it was perceived as potentially inappropriate use of the tobacco funding when it was allocated. Not all of it went towards treatment or prevention or things like that. It got used in a myriad of ways. So the Opioid Abatement Authority is very clear that this funding has to be used to make impacts. Now, I don't think they're going to be expecting an impact in year one, but we need to be moving towards impact. And frankly, it's what we all want, is to make sure that what we're doing is something that's having positive impact, and if it's not, we need to adjust.
Any other initial questions or thoughts?
Standing between them and lunch.
So what we're going to do is get set up for lunch real quick. You all talk amongst yourselves, get to know your neighbors, and also think about the 4 topics again that we're going to discuss after we get back from lunch. Prevention and education, harm reduction, treatment, recovery. Okay? So be thinking about those areas and any points or questions that you want to bring up.
Should we let Dr. Vassell and Taya introduce themselves real
Oh,
quick?
yes. I'm sorry.
Pass the mic
Microphone.
back, just so you can introduce yourself.
Since you
Sorry.
arrived a few minutes late.
Calling you.
So Noelle Bissell, Director, New River Health District, and this is my daughter, Taya Bissell, who's joining me today before going back to school.
We need your voice, the young people's voice.
All right, so give us just a few moments for lunch, and then we'll get started.
Okay.
Okay, thank you.
Should I move this?
Yeah. For your lunch. Okay? That seems like a pretty good deal, right? So again, make sure when you have a comment or a question, you grab the mic nearest you and speak. You don't have to push any buttons, just pick it up, speak into it, and speak loudly enough so the others in the room can hear you. But with that being said, we'll jump into the 4 categories that I mentioned earlier, and we'll just start with the one that seems to make the most sense to begin with, prevention and education. So, in thinking about the topic overall of prevention education as it pertains to opioids, overdose, addiction in general, what are some initial thoughts or comments, questions you have related to prevention and education, what we can do as a region, what we can do specifically in Montgomery County, what we can do here in the eastern end of Montgomery County to improve the situation and address the challenges that we're all facing. Any initial thoughts or ideas or comments about things that we're already doing that are working well?
Or not.
Or not.
Was talking at lunch about the denial of an opioid problem in our region. Like there's certain, I mean, we all work in drug addiction, so we're not in denial. But I don't think people in the community, they think it's maybe a Pulaski problem or maybe a Lee County problem or maybe a Richmond problem. But I don't think there's a real facing of how drugs come into our community, where drugs are in our community. You know, people in Blacksburg just think it's that one block on Draper, you know. And I also think yesterday there was a fabulous article in the Roanoke Times about the impact of the opioid use on the foster care system. So that kind of thing, like realizing that the problem affects all our systems. It affects all our social services, all our education, and kind of getting it out of, well, it's the user's problem.
Thanks, Victoria. Any other thoughts about Victoria's comment or other ideas? Kat?
I've been doing this for 30 years. I think, too, that there's not enough people that understand the underlying cause of addiction, not to blame the person that's addicted, but don't know how to address what it is, and they want a quick fix. You know, just like addicts want a quick fix. I want what I want when I want it. That's a lot of people. They're not willing to train. They're not willing to get trained. They're not willing to know. They pick up on the first quick thing that they think that will stop people from using. And I think that needs to be addressed. You don't have enough people that do the work because it takes hard work to do it. And you have to treat the problem, not the person.
The phrase that you used was underlying cause. Can you talk just a little bit more about that from your perspective?
Most of the people that I have treated in my 30 years had something that they used because using made them feel good. So therefore, there wasn't enough pain for them to not use because of what had happened to them, whether they were abused, whether they were given up for adoption, whether they were raped, or whether they were whatever. And so then therefore, that pain is still there. That drug only takes it away for a little, and when it comes back, they get triggered by something. They go to what they know. And if they don't have somebody that knows how to manage that, then you just, what we call circular reasoning, just going around and around in a circle.
Any other thoughts?
Yes, at the WRC, that's to build on that is one of the big correlations that we see. We see a very strong correlation between domestic and sexual violence and opioid or other substance use, and it works both ways. People who start using substances are many times more likely to be victims or perpetrators of domestic or sexual violence. And the other way around. People who are victims of domestic and sexual violence are much more likely to look towards substances as a way to deal with and fight the pain. In thoughts of prevention, I just wanted to put out one of the things that I think is a really great program is the program called Hidden in Plain Sight. I don't know how many people in this room are familiar with that. I know that they have it at Radford. I'm not familiar with how much it's available in Montgomery County, but I love, getting the idea of talking to parents as well as youth about, looking and identifying what substance use looks like and how prevalent it is and helping to educate parents about what to look for. I think it's a phenomenal program, and I would love to see that expanded.
They do have that in Radford. We actually funded that for the Radford PD a couple of years ago through a grant that we had through NRVCS. I know they've had some changes in leadership within the Radford PD recently, so I'm not really sure what the status of that is at the time, but when we first applied for that funding, got it funded, paid for the project, the chief at the time was willing to take that around to visit other communities to make that available to nearby jurisdictions, which, for those of you who aren't available, Hidden in Plain Sight is basically a program that's educational, informative. It sets up a mock teenage bedroom, adolescent bedroom, and displays different forms of devices and paraphernalia that young people often use, which is designed to kind of fly under the radar and not be detectable by old goats like me. So it is an informative opportunity for parents to educate themselves about what's out there, what's available. And I think, to speak to Victoria's point earlier, I think there's just a lot of denial about the issue, not even specifically opioids. I think it's more broad than that. A lot of people still have the misconception that vaping is safe because it's just water vapor. No big deal, right? But we have kids that are in second, third grade where vape pens are being confiscated by school officials. And if you think about a second, third grader that's using a vape device that is highly potent with nicotine, developing that level of addiction that early in their lives sets them up for some real challenges as they grow and become older. So I think when we talk about addiction, obviously opioids, fentanyl, because it's so lethal, is enemy number one, as it should be. But, you know, we have to think about addiction and the consequences of that in a more broad term, and the exposure to our young people is certainly, I think, a priority for us. Someone was going to say something. I thought I saw a mic. Kat?
Because I work with DOC, probation and parole. So now the problem becomes for us, for me, in treatment, because they can smoke marijuana. So they smoke marijuana, next thing you know, they hurt their back, they start taking opiates, and next thing you know, they're done with marijuana now, they're opiate. Because probation can't do anything to them, because the judges won't do anything to them if they're smoking pot. And I think a lot of people believe, because people get the perception that a person is addicted if they get sick from drugs, and they don't necessarily get sick from not smoking pot. Or that it's okay for them to drink. You have to know the background before you can make that assumption. But it's getting very difficult to treat people that have got addicted to opiates because they were smoking pot. And they can go back to smoking pot. The brain don't care. It just knows you're being put to sleep or you've been awakened. So therefore, it doesn't know whether you're smoking pot or drinking bourbon.
Other thoughts?
Chris?
So I just was going to follow up on some of what Kat and others were talking about with the underlying cause of addiction. And, you know, I think all four things that we're going to talk about today is a whole lot easier understood if we understand trauma-informed care and what trauma-informed care actually is and what it looks like. And, you know, I've been in recovery since 2004. I've worked in this since 2009. And I've not met one person that we label an addict that doesn't have childhood trauma in some form or another. Not a single one. And so when we know the why, then we know what to do, right? And so someone that has, say, sexual abuse trauma may look a whole lot different from someone who has abandonment trauma, but yet we're sending them to the same silo thinking it's going to work for Billy and Bob because it worked for John and Tom, you know, and it doesn't always work that way. So when we look at the underlying cause, and when we're talking about trauma, it's not just individual trauma, it's generational trauma, it's cultural trauma, it's community trauma, it's systemic trauma, religious trauma. There's so much. And I don't want trauma to become like this word, you know, buzzword, but it is what it is. You know what I mean? Like the evidence is there, the data is there. It's scientifically proven what epigenetics is doing to us physically. So I think for us to understand things like harm reduction, prevention, understanding why second graders are vaping nicotine, that would be my first question is, what is the nicotine doing for the kid? Like, what are they missing inside of here that the nicotine is giving them something else? Same with the weed, the marijuana. You know, if we want to know why someone is smoking marijuana, then we need to know what it's doing for them in that moment, right? So whether it's a kid or an adult. So trauma-informed care, I think providers and communities, you know, a lot of us are trauma-aware, but we also, when we say trauma-aware, we say it's them. They've been through some stuff, but really it's all of us that have been through some stuff, from 9/11 to George Floyd to COVID to everything, right? And our kids feel that, and we feel that. So, I'm sorry.
Oh, don't be sorry.
No,
Thank
thanks,
you.
Chris.
That's fantastic. And I did want to, one of the things too about the denial, I mean, I think we have to meet people where they are, and we're going to have to understand that we talked about this a little bit yesterday. Some of the work we're going to do, we're going to start where there's fertile ground to do some work and make some successes, make some strides, and hopefully that helps inform people, bring people along, but not wait for everybody to be on board. What's it? You're just like, you need about 20% of the population to get things moving. And so holding these meetings, talking about what's going on in Montgomery might look very different than what we do in Pulaski, and then look different from what we're doing in Floyd. But everybody has to understand that we still have to be in this together, even if we're not, the road has to be wide enough to contain us all in this work. So, and that Appalachian bootstrapping mentality is something that can be useful and really detrimental to our work too. So we just trying to figure out how we have those conversations with all of the folks. It's going to be really important.
Any other thoughts about prevention and education before we move on? Pam?
I'm just looking at the other bullets, and not necessarily education, but the impacts. Transportation and supportive housing are two critical issues. No funding for it. We know that transportation is a challenge anyway because we're in rural communities, but folks that may have lost their license or the ability to drive because of their substance use, affordable housing, you got to come up with a down payment, then you have to have the first and last month's rent, and we know housing's not cheap anywhere, and it's getting more expensive. So I think the community has to accept that there is a problem and that people need to have a safe place to go as they're resolving their problems and going through active recovery. And I think that's the hardest push, honestly, because that's a tough one. I had this conversation last week with somebody, and they said, well, my husband and I work 2 jobs. I have 3 kids. We don't make a lot of money, and now they're going to give money to people who have not been good members of society. Why are they getting preferential treatment? And that's a reality of people's concepts. Whether that's fair or not, I don't know. But that's part of the pushback. And so when we talk about education, and I don't care about the school systems in this concept, but when we talk about education, awareness is really important. What are the numbers really looking like? And if we can get people healthier and have a more focused approach to economic vitality through workforce improvement, then we might have a chance to really help folks along. I just think that's important. And the other thing is, and I said this at a meeting in Pulaski, NRVCS had a great program, campaign called The Face of Addiction is Mine. And I dare say no one in this room cannot say that they don't know someone who's addicted or even have your own addiction yourself. Maybe you're coping well. So I think that if we can personalize that, we'll go a farther way of being able to get people to understand what this is really about.
Yeah. I do think it's about humanizing this issue.
Back on what she says, the research shows that if a person doesn't have stable housing and doesn't know where his next money's going to come from or whatever, you can forget trying to get him to stop using, because that's a way not to do it. And I don't know if this grant addresses transportation, because then I know when I did Stepping Stones back in the day, we had a bus that just went to get the Stepping Stones people that brought them. And there was lots of people didn't miss the group. People were there because they had transportation. I'm with DOC now. They got to get their own way. Nobody can. And the absentee rate is a lot higher because they live in Pulaski, got to come all the way to Radford, or they live in Willis, or some of them live all the way down in Carroll County. So if we don't fix that, one of those things, look at it, because that is necessary. Because I doubt any of us go hungry. And so therefore, we can manage our life because we're not hungry. And we can get where we need to go because somebody will bring us even if we're not driving.
Well, as I think I've said in one of the other discussions that we had within the last week, you know, you can have the greatest treatment programs and facilities in the world, but if people don't have access to those things, what good's it going to do you, right?
There is on-demand transportation in this proposal and trying to provide services as through the NRV Agency on Aging, who already does some distributive transportation around medical transportation, expanding that so that we're, again, not reinventing the wheel, but enhancing the wheels, helping the wheels spin a little broader in our community.
I do have one more thing about prevention and education is educating family members of people who are in recovery, because the recovery journey is really unique and the kind of compassion and care is different than people who don't understand the recovery journey can provide. And a lot of times, people that I've worked with go to live with an aunt, but the aunt doesn't have any context for the recovery journey, and therefore it becomes a battle, and then that person gives up, for example. So like we used to have the FLASH program at NRVCS, that kind of thing, or Al-Anon or adult children. Those programs are really useful to support the addict in recovery.
Okay. Well, we will then spill over into treatment since we've started to talk about that a little bit on the fringes. Holly mentioned that the project grant will help expand residential treatment access to increase the number of beds through New Life Recovery Center, the one residential treatment facility we currently have in the NRV. It's a drop in the bucket, admittedly, even to go to 17 beds with the level of need that's out there. But that's one direct impact of this funding. But what are some other things around the realm of treatment that you might consider, suggest, or have concerns about? We know transportation access to that care is incredibly important. There's not enough of that right now. What else?
Where are they going to go when they leave residential? That's the thing. They leave residential and there's no follow-up, there's no nothing, because I'm cured now. I've had residential 2 weeks, 3 weeks, whatever. No aftercare, no relapse prevention groups. And it specifically says in the research, if a person has at least 18 months of recovery treatment, they have a better chance of having sustained recovery for a long time. But that doesn't happen. Like my group now doesn't have anything to fall back on after they leave me. Some of them relapse, some of them don't. So does that grant provide for groups after residential, or to pay people to do that, or what?
Still some of the specifics that are being shaken out, so to speak. NRVCS has plans to hire more staff, which would allow a lot more intensive in-home treatment and follow-up. As for some of those, we've also been talking with folks at Eagles Nest and other groups. I mean, NRVCS is one, there's no single path to recovery, and we're going to have to talk to all the folks and engage everybody around this. The idea, too, is that some folks, a lot of people who are using when they decide to go into recovery never go into an inpatient treatment. So how are we addressing outpatient treatment? How are we addressing, some of those family wraparound services? And we know that there are things in here about food insecurity, housing, the supportive housing work that New River Community Action is already looking at. And we're also talking with folks around transportation and employment. Like, how do we make sure that there's paths to actual recovery that are broader than not using drugs in this community? So definitely that's a part of it. And I don't know, Dr. Bissell, if you want to speak to the mobile clinic too, in addition to addressing people's access individually to services and things like that, if we can get the mobile clinic out, our hope is that provides another level of access to a variety of treatment as well as information and education, that people can get services in a lot of different ways. Do you want to? Yeah.
We want to offer all of our health department services and just increase awareness about the health department. One of the most frustrating things is that the health department, is basically known for STIs and uninsured, right? And we do a lot more than that. And the population we're trying to reach, if we do reach out to offer syringe exchange, harm reduction, that population does have a lot of other health issues that need to be addressed. That, we can test them for hepatitis C and get them into hepatitis C treatment. We can test them for other STIs and HIV and syphilis and those kinds of things. We can provide birth control. That's a huge part of this, right? And we had a really successful program in the jail that unfortunately kind of got waylaid because of COVID. But we went in and we taught about family life and about pregnancy prevention and about STIs, and then we offered them contraception right there in the jail. And we had a really good uptake. People would take long-term contraception. So just being able to offer those services and make sure people know what the resources are. I think that's a huge thing. A lot of people don't know who does what and where those resources are. So if we have those contact and we have people like Chris out in the community, our community health workers who are getting the word out, that's a big goal. And taking it to them and then hopefully being able to connect them with those transportation resources, so when the bus isn't there, but they need to get to the health department or they need to get to NRVCS, they have the resources to call and to rely on. And part of we'd like to partner, Dave Roberts with our community health center is very invested in this. NRVCS is very invested in this. And so I don't want to do things that others are doing, but bring them along with us. So if we take the bus out and we have somebody who can do MAT while we're testing them and offering them contraception and getting them clean syringes and getting them the naloxone. And you're right, the data shows that Chris used it as it's a gap that we need to cover between active use and recovery and meeting them where they are. And if they're not quite ready for those recovery steps, at least we're providing them those services so they feel like we value them as individuals, we value them as people, that they deserve the same care and compassion that everybody else gets.
And that new mobile facility is impressive. If you've not seen it, it is very impressive. But I think Dr. Bissell, you mentioned this in the meeting last week in Pulaski, we don't necessarily want this to be described or known as the drug bus either.
Yeah.
That's where all the
Used to
the
be
people.
the sex bus.
Yeah. So making just a broader spectrum of services, care available for folks who need that access, and then to be able to get that around to the various points in the community that don't have access to public transportation or nearby facilities.
Kind of back to what Pam's point about the idea of prevention it's targeted at particular populations that we know are at higher risk, and people who are struggling to meet their basic health needs and access to it will be available to them too. That's all part of prevention. The idea is we're creating an ecosystem that everybody can access this, and that it does invite us all into solution of the problem of opioid addiction. And it also understands that there isn't one way that happens for folks. We all have supportive housing if we're living in a house that's meeting our needs. It's some version of support that's happening for me and others who have that. And so what we really want is everybody to have access to that kind of support.
And I think we would all probably agree that health literacy or lack thereof is a huge, huge issue in our communities. And so it just stands to reason that there's a real lack of education, awareness, understanding of addiction, and that being a disease. And so it's spilling back over into prevention education, but I think that's a big part of this, is just making folks more aware of the disease itself. And just like cancer, not all cancers are treated the same. Not all addictions should be treated the same. they are uniquely individual. The path to recovery is as unique as the person, and it doesn't always look the same. So,
And the education is for our partners too.
yes.
Nobody, we need education about what everybody else is doing, and it is a lot told in your head, so trying to figure out a process by which we communicate that and figure out ways to bridge. So somebody going to the emergency department, they know how to refer them to a service that will provide services beyond what the ED can do. And I think we all want that. Sometimes it feels tricky because there are regulations around how we share data with each other, but I don't think we should let that stop us from trying to find a way that this information can be shared effectively and safely with each other.
Yeah, and some of that information, enlightening, needs to be shared with landlords, property managers, business owners, to make sure that folks are able to access some of those resources and they're not stigmatized
Even
or treated like
employers.
second-class citizens.
And employers.
Yeah.
One of the things we've talked about is treatment opportunities on site for some larger employers. Like, people travel a long way for their methadone or their buprenorphine treatment right now in a lot of places. And some people think, well, we don't really want that. It even came up in one of our meetings. Well, maybe you don't want that in your county. I'm like, if you've got use in your county, you need treatment in your county. And so I think we all need to have some conversations, some hard conversations about what that looks like and what it does not look like. And when people make mistakes about the way they do treatment, we need to talk about that too, just as we need to talk about the need for access.
The other part around treatment that I'll speak to quickly is just the workforce issues. The workforce shortage, we don't have enough providers. We don't have enough folks doing the work. The level of need and request for services continues to climb while our workforce numbers are going like this. So we got to figure that problem out too. Pam?
Just something that's unique about us, I think, is that we do have Radford University and Virginia Tech, and we're about to be repopulated because of all those students coming back. And I know they have their own recovery services and their recovery plans, but I was asked specifically last week, is this available to them as well as being transient residents, because they don't want the stigma of someone at Virginia Tech or RU knowing about their issues. So is that something that, how do we get that message out, right?
That would be a great, one of the things we're already talking, part of the reason I invite folks from Tech to come is, they are part of our community. Radford's part of our community. New River Community College is part of our community. And we've got folks, when those folks are here, they're here. Like, they're our neighbors, they're our, and so having conversations, I think, about what that looks like, what that appropriate looks like, and I guess too, there isn't going to be the Virginia Tech model. There's going to be, a variety of models that hopefully people at Virginia Tech or Radford or community college could access that makes most sense for them. But I think that's got to be part of it, and we also know that they're a highly at-risk population too for this.
So I guess part of the question that they had was, is there funding available to help support their recovery programs as well in this? Is there something that we can do? Because I know Cora at Radford has been writing grants and trying to get money and trying to get funding, and she's really struggling with it. And then all of a sudden this money comes in the back door, and it's like, how do we get a piece of that pie specific for her project?
We've been talking with her already. I think it's very possible there will be something. I think we haven't got the money yet, so I can't quite say exactly how it's going to redistribute. This is a 5-year grant, so maybe there's going to be some relationship and trust building that we're going to have to do across the board with all of this work. I do think that there are ways for individuals to access the services that might be available through this process immediately, and then what we'll need to do is talk about if there's programming on the campus, as long, again, as the campus programming might be available to a broader group of population too. Hopefully we can break down some of those silos, like this is for Tech, and this is for Radford, and this is for the community college. This is for our people, and different people need to access it different ways.
Cap?
Educating people. There's lots of, and I'm not just throwing this out for some, there's lots of nurses, doctors, people that don't understand addiction either. And this is an example. I went to, and I won't call the name of the hospital, and I knew I had a kidney stone. I've had them enough to know. And because I had some medicine that would show up in a drug screen, when I first went and said I had a kidney stone, they was just so lovable to me, just kind as it can be. But the time I gave them a urine sample and they tested it, then I became one of them. That burned me to no end. And so I think we think that professional people understand, and I think they need to be educated too, and not look at those people. And that was my first experience on the other side of being looked at, besides my color, being looked at because they thought that I was an addict.
Yeah. Long
Thank
way
you
to
for
go.
sharing that.
Yeah. Yeah.
Yeah, Sarah.
So, first of all, I'm really sorry that you had that experience because I'm a registered nurse and I saw that happening as well. So if you have ideas of what could be done, please let me know because there are people at Carilion that are interested in taking action. Our Carilion system has rolled out Revive training for all of our employees, and over 1,500 employees have either taken the training or they're signed up to take it. All Carilion employees can get free naloxone from Carilion pharmacies if they would like that. And then also, I come bearing talking points from Charlie Teresides, who is a pharmacist at Carilion and is the subject matter expert on this, not me. So he is working with VTC, so Virginia Tech Carilion in Roanoke, and then also VCOM to develop a curriculum for harm reduction, addiction treatment, stigma, language, etc., for the substance use disorder patient. And then also trying to create educational opportunities for those students in addiction medicine, harm reduction, and overall substance use. So there is work being done, and certainly there are more opportunities. And if anybody knows of those, let me know.
Thank you, Sarah.
Noelle would like a mic.
So, yeah, I mean, I can say I graduated from medical school in 1990, and there was nothing about substance use or addiction. And then I did my training at the time when the drug companies paid the money and pain became the fifth vital sign, right? And so, you know, doctors who weren't treating pain were bad doctors. You got to treat the pain, you got to treat their pain. And, oh, you know, we have these remarkable drugs. So it has to be part of educating our new and upcoming medical students in all professions, our new assistants, our new nurses, our new physicians, our new PAs and NPs, absolutely. The other thing, you know, like as we're talking about trying to roll out harm reduction, that's and syringe exchange, that's obviously a challenge with our law enforcement community. And so we look for those people that are kind of our spokesmen, our ambassadors. And I don't know how many of you know, but Chip Schuler, who's the sheriff down in Smith County, was a big advocate for starting it because he saw the toll it was taking on their community. I will say, and Chris brought this up at the Pulaski session about how in the emergency department, people with substance use problems are treated terribly. And we had a personal experience with a son of mine who had had a surgical procedure and was having uncontrollable pain. And the first assumption was that he was drug seeking. So, you know, we have a lot of work to do in that area. I will say John Burton, who is an ED physician with Carilion, is the perfect champion because John came around, and Beth Macy talked a lot about that when she spoke at New River, about how John was kind of one of those folks that just thought that this was perpetuating the problem. And now in Roanoke, they've started, with the Hartmans, they've started MAT in the emergency room and a warm handoff. So there is hope there. I think we have to find the John Burtons to be those ambassadors and those spokespeople who get out and help educate in our medical community for sure.
Other thoughts?
Medically assisted treatment, sorry. I try to say that whenever there's a.
Pam?
So one thing I learned from Kat early on when we were working in Pulaski together was that she'd look around the room and say, where's a person who's using? Where's a person in recovery? Why are they not at the table telling us what they need? How dare we stand here and think that we know what's best for them when, with the exception of a few people, are not at the table with us? And I guess that's my plea to everybody is talk to folks, get rid of that stigma, invite them to these meetings, find where they are meeting and go there and just say, I'm here to learn because I don't understand this fully, and what can I do to help you help yourself so that we can have a better community. And I just implore all of you, and I don't care if it's through the faith-based community, I don't care if it's through going to the 401 Peer Center and just dropping in and having a conversation. I just think it's so important because if they're not at the table, they don't have a voice, and we're making a lot of assumptions about what they need for their best interests.
Thank you, Pam. Other thoughts around harm reduction? We've talked about syringe exchange. We've talked about naloxone, which should be available to everyone, by the way.
Xylazine strips.
And it is free through the health department and NRVCS. If you haven't gone through that training, make sure that you get in touch with one of us to get set up for that. It's easy, it's not rocket science, but it can save lives. So you need to make sure that you've got access to that. Everybody should have that.
We're just whispering over here about fentanyl strips.
Yes.
Xylazine strips.
Yeah. You want to talk about that, Chris?
Yeah, so I've been working in harm reduction the last 2 years. I worked at Virginia Harm Reduction Coalition in Roanoke City and also did Smith County with Chip Schuler. We did syringe exchange to the health department, and so that was a one-on-one. But we also, what we did was get out fentanyl test strips, and now we have xylazine test strips, so people can test their product to see if it has fentanyl or xylazine in it. It is, I can tell you stories of how many lives that it's saved. You know, there is some education that needs to go around the use of the strips and how they're used. Because, I mean, just an example, like if you test methamphetamine without diluting it with enough water, it'll show up for fentanyl every single time because of the chemicals in the methamphetamine will react with the test strip. So you got to use a lot of water. So those are the things that have to be educated or we're going to potentially create another hysteria unnecessarily, right? You know, I think I did want to say something too about, you know, us kind of sweeping this under the rug some places in the River Valley like there's not a problem here. I can assure you, because I like what Pam said about getting out and meeting with these folks. That's exactly what I've done in the River Valley, especially in Pulaski. And I see 30 to 40 people in Pulaski a week who are actively using drugs, who need clean supplies, who need naloxone, who need food, who need some clothes, who need a tent, who need tarps. They need all these things, right? But sometimes we're more focused about getting them into treatment. Some people aren't going to come to treatment because they don't feel safe anywhere, right? So until we can get out there as human beings and talk to these folks and say, hey, this ain't about the drugs for me. This is about what can we do for you or what can I do for you? You know, a lot of times, you know, I was taking people's stuff like, I'll just use an example, injectable naloxone. They don't want injectable naloxone. They're scared of injectable naloxone, so they don't want to touch it. So they'd rather have the nasal. It's stuff like that I didn't know, you know what I mean? So in stuff like sterile waters, I give them sterile waters so they don't have to go to the toilet, or sometimes those little bottles. If you've ever been into like a Sheetz or something and your little water bottle's leaking, it's because somebody stuck a syringe in there to clean their syringe to get clean water, right? Happens more in the big cities than it does here, but it happens. And so stuff like that is a community public health concern, right? So any which way you want to look at this, love and compassion is the foundation for other human beings, and from there you can do what you want with it, whether it's through faith, through your work, whether you're a doctor. But we got to understand that this has been shame-based for so long that 110,000 people died last year, which is 2,000 more that died the year before that. What we've been doing hadn't been working, right? So we'll do something a little different, and I love this approach that the New River Valley came together and put all their funds together because this is going to be huge for us as a whole, for everyone, as long as we do it together and right.
Hey, Chris, while you're talking about this, can you talk about kind of the long game with the needle exchange, the idea, the real payoff there? That it's not just about needles.
Yeah, no, it's so what I tell people is that, people see the syringes, and the biggest thing I hear is, well, you're just enabling their drug use. That's the big ones you're enabling. And the reality is, for us as harm reductionists, the needles are just an incentive to get them to come and connect with us so that we can help keep them safe. You know what I mean? Like, I don't care about the syringe. All I care is seeing them face to face and seeing what because sometimes they come to us with some wounds that make me want to puke. I'm not going to lie. Like, I have seen maggots in people's feet, right, from infection. It's awful, right? That doesn't need to be happening. And I haven't seen that in River Valley. What I have seen in River Valley is a whole lot of overdoses, So the syringes are an incentive to get people to come and connect with us, right? And then from there, the data proves that harm reduction works. Like, the data is there. It's just, we got to start implementing it, right?
Yeah, perfect. And then obviously, with folks using dirty needles, supplies that aren't sterile, you run the risk of infections, hepatitis C, HIV, AIDS, all the things. And the New River Valley has a pretty high rate in those categories. Surprisingly high, I think. Shocking to me to look at those numbers. So it is a public health concern.
One of the things I'd invite all of us to do is ask yourself this question: do I know as much as I need to know at this point in time about this disease of addiction? Or do I just know a few things? You can learn a lot from the addict themselves, because everything I know I didn't get out of a book. I learned from those people that I worked with for 30 years or whatever, and people that are in recovery. But we think we went to Radford University or we went to Virginia Tech, and we know everything there is to know about everything. And I just always would say, I know nothing today, I will learn something today, and I will still know nothing. So just ask yourself and be honest with yourself, do I know what do I know about this disease of addiction, and who do I need to go to find out something? And it's people that are addicts, that are actively using, and people that are in recovery. How did they get there? What did they do?
No, you're fine.
Well, I'll just segue up what Kat was saying about your services and making sure that this funding of education includes peer recovery specialists, because they are really key to reaching people, especially because of the safety factor that Chris was mentioning, and also peer housing like Oxford House. Those kinds of peer support services, I think, are really important to the recovery journey.
Going along with the peer, so the peer right now, I'm just going to talk a little bit about the peer service, because a lot of people don't know a lot about it. But the state of Virginia, we have certified peer recovery specialists, so we had to do a 72-hour training, then do 500 hours of paid or volunteer supervision, and then we take an exam, state board exam at the end. And so we've been working with New River Community College, because when I started doing peer work, like, I was put into this role. And, like, I could do, like, the talking part and sharing my experience, strength, and hope. But when it came to documentation or proper language or HIPAA or basic counseling skills or public speaking, I knew nothing. So we've lost a lot of good peers because they get put into these roles and they can do one part of it, but they can't do some of the most important parts that keeps this thing rolling. So we're working with New River Community College to hopefully get some kind of certificate for peers that includes those basic courses. And hopefully we can get some scholarships for it too, so we can get, like, maybe some drug court participants or something that wants to be a peer involved in that, get that ball rolling, because I think educating our peers are important too, because this is, like I said, I've been doing this work for a while, and it is so important that we take care of ourselves mentally, physically, emotionally, spiritually, all that stuff. And when you get overwhelmed with work as a peer and you feel like you're inferior or you're not good enough or you don't belong here because you can't do the work, then it leads right back to relapse or worse every time. I've seen it happen, including to myself, right? So we got to take care of our peers 100%, and I think educating them is a big, important part of that, and also spreading them out to different places in the community rather than just CSBs or just community, just certain places. They need to be everywhere. EMS, law enforcement. There's a place in Richmond. I love this. They bought, well, maybe I shouldn't love this. It's a little sick. They bought bulletproof vests that says peer recovery specialist on it, and they ride around with law enforcement. And so when they come up on someone who's had an overdose or something like that, then the peer goes out and talks to them and hangs out with them. And I just think that's awesome. So that EMS, get them in emergency rooms. We tried that before. It wasn't very successful. Maybe we can try it again. I don't know. But the peer thing is very, very important. My thing with it, though, too, is that we're all peers. Everybody in this room has a story, right? So I think also we kind of need to bridge that gap of peers and them. You know what I mean? Like we're all in this thing, so yeah.
I love how you all are perfectly segueing into our next categories. So let's talk about recovery in addition to the certified peer recovery specialists. Any other thoughts about recovery and how we can better support folks who are actively in recovery or to help them get to that point? We talked about housing, transportation, all those ancillary things that folks need to live healthy, productive lives like the rest of us.
They gotta have support because we have taken away old people, places, and things. So they've got to find new people, places, and things because we are social human beings and they've been used to being out. And so whether it's going to the fellowship or whether it's going to faith-based programs, whether it's going, we have got to encourage them to find, because they'll say, well, everybody I know uses. That is the truth. Everybody they know uses. So we have got to help them. So we have to know where the meetings are, where because not every meeting is a good meeting. Some of them are not, because it's sick people in the room trying to get well. And so we need to know what's happening. And if you've never been to a meeting, you might want to go. But that's what we have to we have to replace what they're losing. We have to have things they can go to, like there's a place in Roanoke called Rebo's. That's sober, spelled backwards. They have things that they can do, activities that they can do, and people go there and just hang out and do them because that way they don't have to feel like they're missing what they was missing when they was in the street. It's sober people. We used to take them, when I was at New Life, we used to take them to the movies. You wouldn't believe how many of those had never been to a movie sober. They thought that was the most wonderful thing in the world. Those things they hadn't done. So we need to, when we have them, we need to think about what kind of activities can we have to replace what they're missing, the fun and things they thought they had when they were using.
That's a great point, Kat. Other thoughts about recovery?
I have a question about grant money. Is it specific to office-based treatment? Like these treatment programs don't have to be connected to medical-assisted treatment, right? Okay, good.
I mean, I think, again, we keep saying there's not a single path.
Right.
So we're going to have to figure out multiple paths. I don't know, Annie, if you're willing to talk about the trauma-informed care, some of that stuff, too, that we're doing, because I feel like saying that, but I also want to figure out how we have to figure out ways to disseminate some of this, too, so.
So a little bit going back, but I'm the chair of the NRV Resiliency Network, which is our area's trauma-informed community network for the state. And so part of what we've been doing, and we were already working on these efforts through a grant with the Department of Social Services, so this is all really good timing, but we're working to increase the amount of trainers who are trained in trauma-informed care. So we have done a train the trainer. Our goal is to then provide those trainings to anyone in the community. So as we were saying before, we all need this in every department, in every agency, and not just for folks in the human services arena. So that is our goal. By increasing the amount of folks who can do these trainings on trauma-informed care basics, we can spread them and get all of that information out. so that we have the similar language, similar understandings and awareness about the topic of trauma, which, as we know, is one of the biggest underlying causes of SUD and these issues. And so with that, we're also looking to do kind of modules dependent on what group we are working with. So, you know, for folks just wanting basics, we can provide that, but also folks who are doing more with in person with children or families, we will have work around those areas as well to give them those skills. So those are efforts we're working on now, and hopefully we'll be kind of spreading that as much as we can, hopefully works with this grant, because I think that that's what we need, you know. We've gone through a community trauma, and so I think we just all need to kind of go back and look at what is trauma, and, you know, asking, you know, instead of what's wrong with you, what happened to you, you know, and getting everyone looking at it from that perspective.
Thank you, Andy.
Hey, can you talk about drug court?
Kind of an overview of what it is. Sure. So for those of you who aren't aware, we do have drug/recovery court programs in all 5 jurisdictions in the NRV. That's basically a program for folks who are nonviolent offenders that have legal issues, obviously, that they can then get those charges dropped if they successfully complete this program, which includes like really intensive counseling, case management. They have to appear before the judge every 2 weeks, I believe. So there's a lot of compliance and adhering to the guidelines of the program. But a lot of folks, again, it's not for everybody. This isn't something that works for everybody. But for the folks who have been successful in it, you know, the structure and support that they get during their time with that program is helpful. But again, it is for nonviolent offenders. There's a team that works in each of the drug courts to evaluate potential candidates for the program to determine whether or not they'd be a good fit. And obviously the participants got to be willing to adhere to the very stringent guidelines that are laid out for them. But we've been doing that since 2014. The first one started in Pulaski County. And as I said, we've now got programs in all 5 jurisdictions. So again, not for everybody, but for some folks, it's proven to be effective.
A way to expunge those charges too.
Right.
So if folks are, one of the things that does come up a lot is, you know, the ability to re-enter the workforce, to get housing, you know, to qualify for any of the services that are available. Well, yeah, sometimes that can be a real incentive. But it is very rule bound.
Yes. So, any other thoughts in general or questions or ideas about how to move forward? Dr. Bissell?
Make sure to get the word out that recovery is, no one knows it better than Chris, but recovery is a journey. And just like any other medical problem, you're going to have relapses and recovery, right? So we got to make sure as we're doing this education and awareness that the idea that someone's going to recover and be done is just not realistic, and that it takes multiple times where they might achieve some degree of recovery for a period and then they may relapse again. So just like any other chronic disease, it is going to have relapses. And so expectation management, people need to understand that it is just like anything else, a journey. And that one time, it's not going to be one and done.
Absolutely. Other thoughts?
So I know someone personally who is struggling in recovery because they feel like they can't go back to the same workplace because drugs are there. Their friend group, drugs are there. So trying to get them into a better environment that's not around them. So that's the biggest reason why they're struggling in recovery.
We actually, I know a few folks who have been pretty successful with the drug court program that have entered the workforce, gotten pretty good jobs that are paying a pretty good wage, but they've had to quit their jobs because they didn't feel safe in in their recovery because they knew that drug use was rampant within these work sites. So it was jeopardizing their recovery, and they had to walk away from a job that was paying them a decent amount of money so they could actually live and get on with their lives. Go figure. Chris?
So I got to, there's a factory in Pulaski called Marball, and it's pretty known for having people who use substances work there. They've had a problem with it for a while, so I went and did a naloxone training for their staff, like their managers and supervisors and stuff, and I think that's a good approach to take for some of this. And also, I think, and something I haven't really thought about too, is kind of the recovery community itself kind of needs, don't necessarily need, but probably would benefit from some of this information about this ecosystem that's going on, because things like the Peer Center, more of those could pop up. You know what I mean? Not necessarily from this funding, but, you know, all it takes is an idea, you know what I mean? And people can roll with it. So I think getting people in recovery connected to more people in recovery, because there's a thing in the recovery community too where it's like 12-step versus the world. And, you know, it's 12-steppers need a place to go too. You know, you won't find a meeting where everybody in that room is abstinent anymore. You won't. Everybody's either MAT, cannabis, or something. You know what I mean? It's like, I haven't seen one in years where you go to a meeting, every single person sitting in that room is 100% abstinent, right? So I think getting the recovery folks connected together and understanding that folks need a place to go to feel safe. And once you go to that place, then you connect with other employers, other ideas to maybe create your own, whatever. A lot of successful business owners have started, you know, once they got through treatment, started businesses, all kinds of stuff. So it's there. I think, again, it's the connection piece.
All about relationships at some level. Other thoughts? If this clock is accurate on the wall, you're going to get out of here early.
Yeah.
So everyone is on the sign-in sheet that went around, right? We've got your contact info. That's a great way for you to stay up to date on what's going on with this project and our work in the communities, specifically through our prevention coalitions. If you're not already tied in with one or more of those, we'll send you some information so you can potentially become actively involved with those groups. Sort of a grassroots approach to trying to address wellness in general in our communities, but obviously addiction, mental health concerns are a part of that. So just about keeping the relationships connected and working together. That's what it's going to take. It's going to take all of us to get behind this, to approach it from a place of empathy, understanding, support, and love. So thank you all for your time this afternoon.
Thank you.
Thank you.